Welcome to this month's Techniques in Coloproctology virtual session featuring the recently published article titled Learning Curve Analysis for Prophylactic Bilateral Robot-Assisted Lateral Lymph Node Dissection for Lower Rectal Cancer. Today's presenter is author Dr. Toshinori Sueda, and the moderator is our very own Editor-in-Chief, Dr. Rodrigo Perez. Our associate editor, Dr. Tsuyoshi Konishi, is assisting with moderating and translation.
Excellent. So, welcome everyone to the virtual session for Techniques in Coloproctology. Today, we are fortunate to have Dr. Toshinori Sueda from Japan, Osaka International, and he's going to share with us the data from a study who has recently been published in Techniques in Coloproctology. It speaks about the learning curve of lateral node dissection in rectal cancer using the robotic platform. This is how this is going to work. We're going to have Dr. Sueda present the data, and we're going to have co-moderating the session with me, Dr. Tsuyoshi Konishi, who is currently at MD Anderson. And we thank you, Tsuyoshi, for your kind presence and willingness to be present together with us. Of course, if we need help in translation, we will ask you to help us in terms of translating any difficult questions to Dr. Sueda. So thank you both for connecting. Dr. Sueda, thank you again for accepting to present. You can share your slides and you can address the audience. Thank you very much.
Good evening, everyone. Thank you for the kind introduction. And thank you all for joining today's live session. I'm Toshinori Sueda from the Osaka International Cancer Institute. Before we begin, I'd like to thank Professor Perez, editor of Techniques in Coloproctology, for the opportunity to share our work. Now, I'll share my slide. Can you see my slide? Okay.
Yes, we can. Thank you.
Okay. Today I'm presenting my study on learning curve analysis for prophylactic bilateral robot-assisted lateral lymph node dissection for rectal cancer. This work looks at how surgical proficiency develops over time and what that means for training safety and clinical practice. Let's begin with a key takeaway from our findings. True proficiency in RA-LND tend to develop after about 36 cases. And that's when we began to see consistent improvement in operative time, blood loss, and post-operative complications. And this marks a turning point in learning curve with clear implications for both training and patient outcomes. To understand why LLND matters, it helps to look at how to treat low rectal cancer in the West. And the standard is total mesorectal excision with preoperative chemoradiotherapy and total neoadjuvant therapy. But in Japan, we routinely add LLND, especially for lower tumors, because radiation alone often doesn't cover the lateral pelvic. Data from Japan show that LND can significantly lower the risk of local recurrence. Even with advanced operative therapy, a surgery still plays a key role. LND isn't just a backup for radiation, it can be powerful complement. But it's a demanding procedure that requires precise anatomical understanding. However, the best data on how surgeons acquire proficiency in robot LND are still lacking, which is exactly what we set out to our study. So before we get into surgical technique itself, let's take a closer look at the anatomy that guide us during LND. Let's start with muscles. No, sorry. To perform LND safely, we rely on four key factors: muscles, nerves, vessels, and fascia. These landmarks guide the dissection and help us stay oriented in a very tight space. Having a clear three-dimensional scene of these layers is key. It helps avoid injury and make the dissection smoother and more controlled. Let's take a closer look at each of these one by one. Let's start with the muscle. The pelvic floor muscles form the outer edge of dissection space, and they help define the lateral boundary. By staying oriented to these structures, we can work more precisely and reduce the risk of injury. Let's move on the nerve. A pelvic nerve close to fat and lymph nodes we are targeting. So during dissection, we are often working right next to them. Identifying them early helps us lead an anatomy more clearly and avoid damaging the vital for urinary and sexual function. Next, let's talk about the vessels. Major vessels, like the internal iliac artery and its branches, pass through the same narrow space we're working in. When we overlay this vascular map onto the muscles and nerves, it helps us understand the anatomy in 3D and plan a safe, clean dissection. And finally, the fascia. Two key fascial planes guide this procedure. Staying inside these planes helps define the dissection area and protect the structures we want to preserve. Following these layers closely is one of the most important steps in performing RA, LND safely and reproducibly. With those landmarks in mind, we can define the dissection area. We target the internal iliac nodes, station 263, and the obturator nodes, station 283. And these lie deep in the lateral pelvic compartment, surrounding by the structures we just reviewed. Knowing this exact position helps us remove them safely and completely. So what we're trying to learn, and we wanted to see how learning curve affects surgical performance in RA and ND, and focused on three main questions. First, how does surgical efficiency, especially operative time, change with experience? Second, does this translate into better clinical outcomes, such as less blood loss and fewer complications? And third, how many cases are needed to reach a level of proficiency where those improvements become consistent? Here's our study design. We look at 58 patients who had prophylactic bilateral RA LND with TME. Surgeries were done by colorectal surgeon experienced in robotic TME but new to LND. And this method allowed us to identify infection points where performance began to stabilize, offering a more objective way to define surgical running progression. And this shows our standard port placement using the bench XI system. We've used 5 ports centered along the umbilical camera port. And once the TME is complete, we move on to the LL and V, following the anatomical guidance we just worked through. Let's take a look at what the surgical field looks like after the dissection is complete. Here's what the field looks like after completing dissection. The internal iliac and obturator nodes have been removed, and key structures like the ureter, vessels, and obturator nerve have been preserved. The dissection follows clean planes, showing how good anatomy supports surgical quality. To track the learning curve, we used cumulative sum or QSUM analysis. It's a simple way to track how each case performs compared to the average. This method helps us spot patterns more clearly and understand how surgical skills develop over time. We define three phases: running, competence, proficiency. Then we compared phase 1 and 2 with phase 3 to see what changes with experience. I'll walk you through that shift in the next few slides. Before applying QSUM, we'll look at operative time by case. As you can see, early cases clearly took longer with wide variation. Over time, the procedures became shorter and more consistent procedures, hinting at a structured learning pattern. That's what prompted us to dig deeper with QSUM. This is a QSUM curve for all cases. When a case takes longer than average, the curve lies. When it's shorter, the curve drops. And overall, you can see a clear progression, a structured running curve emerging over time. In the following slide, I'll walk you through each phase and show how surgical performance evolved along the way. Phase 1 covers the first 20 cases. This was the adjustment period, getting used to the robotic system and the pelvic anatomy. Operative time were the longest and outcomes varied widely from case to case. That reflects the challenge of learning to navigate the control lateral pelvic space safely. It was the steepest part of learning curve, where precision is built through repetition and adaptation. Phase 2 include cases 21 to 36, and this is where performance became more consistent, and surgeons grew more confident in identifying landmark and managing the robot arm smoothly. The technique was still being refined, but there was a clear shift from basic adjustment to consistent performance. This phase marked the true turning point where the foundation was in place and the surgical performance became more reliable. Phase 3 begins after case 36, and this is where we see true proficiency take hold. Surgeons operated with more confidence and control. Operative times were consistently shorter, dissections were cleaner, and key structures were handled with greater precision. They stayed within anatomical frames, avoided unnecessary movement, and the entire procedure became more reproducible and stable. This phase reflected not just skill, but surgical maturity where speed and safety were finally balanced. So, to step back for a moment, here's the big picture. In phase 1, surgeons were just getting used to the system and getting familiar with pelvic anatomy. In phase 2, technique became more consistent and confidence took hold. And phase 3, their proficiency was achieved with faster dissection, better control, and more stable outcomes. This progression really showed how structured stepwise training can lead to safer, more effective RNND. Our surgeons related the proficiency phase around case 36. We saw consistent improvement in surgical performance. Operative time dropped by about 20%. Blood loss was reduced significantly, and LND-related complications, including urinary dysfunction, fell to zero. At the same time, oncologic quality was maintained across all phases, with no decline in lymph node harvest or pathologic outcomes. These findings suggest that efficiency and safety can improve together without compromising oncologic standard. From a training perspective, this running curve offers a practical benchmark. This shift around case 36 can be used to guide credential policies or define milestones in structured training programs. This approach may be especially useful in practice systems, high-volume robotic centers, or surgical fellowships. Objective data like this can help standardize the learning process and promote safe, scalable adoption of RA-LNND. In summary, proficiency lived after 36 cases, complication rate dropped, learning curve support structured training. Thank you for your time and attention.
Excellent, Dr. Sueda. Very kind of you to share. This is interesting data. As people start to send questions and here in the chat, I'm going to start asking myself a few questions. Can you share with the audience what was the level of the surgeons who are beginning their experience? So these surgeons who are doing the lateral node dissection were fellows. What kind of experience or previous experience did they have when they began their journey in terms of robotic lateral node dissection?
I'll translate. 末田先生、質問はですね、このデータ、ロボットのこのデータを始める前に、要はそのサージャンのレベルっていうのはフェローだったのか、それとももうすでに素行覚醒に慣れた先生方だったのか、どういう方がこの対象になってるんでしょうか。その初心者なのか、それともすでに素行覚醒には慣れてるスタッフがロボットを始めたというデータなのか、どういうセッティングでしょうか、これは。英語でも日本語でも大丈夫です。
Okay, nice question. All surgeons involved in the study had already completed over 40 robotic TME cases before performing RA, L, and LD. This baseline robotic experience likely showed the adaptation period and helped surgeons navigate a lateral pelvic compartment more efficiently. It also provided the necessary dexterity to manipulate robotic instrument with precision, which is especially critical in RLD.
So if I understand correctly, these patients, these surgeons were quite proficient in TME, but not yet on lateral node dissection. We know that lateral node dissection is not per se a difficult, technically demanding procedure. Instead, is the understanding of the anatomy. So I'm thinking here that they probably have seen many lateral node dissections before actually performing lateral node dissections. So they actually had at least some experience in terms of anatomical landmarks, even though they haven't or hadn't performed any lateral node dissection, correct?
彼の質問はですね、要は素行覚醒に関してどのぐらいの経験があったのか、ある程度も見たことがあって、例えばラパルの経験とかがあったのか、その素行覚醒に関しては初心者だったんでしょうか。
すいません、日本語でもいいですかね。
もちろんです。
日本語に素行覚醒に関しては腹腔鏡下で経験はあります。ただロボットに関しては、経験はありません。なので、解剖学的な知識っていうのは、十分持った、ドクターが行っています。
Okay, so his answer is basically, this study setting was in a high volume center in Japan, which is a JCO group, one of the highest volume centers. And basically, the surgeons participating in the study had a good experience on lateral node dissection itself, but actually no experience on the robot. So basically, this is on the setting that surgeons are already has enough anatomical knowledge, usually either open with or laparoscopy, but no with a robot.
So they knew what they had to do. And what we are really testing is how they do it with the robot.
Exactly.
I understand. So my final question, and perhaps you could translate again, Tsuyoshi. As I understand, all of the lateral node dissections here were prophylactic. Does he believe that in the presence of suspicious nodes, it would be a little different? Or how does he think that a surgeon becomes proficient in doing this in the setting of suspicious metastatic lateral nodes? Okay, because we know it's slightly different.
Yes, I'll translate. このスタディのセッティングは予防的素行覚醒だと思うんですけど、実際に欧米でされるような予防的な、治療的な素行覚醒ですね。実際に腫れてるリンパ節がある状況でのその素行覚醒に関しては、どうでしょう、だいぶやっぱり主義としては違うと思うんですけど、やはりラーニングカーブとしてはもっといるんでしょうか。これはあくまでその予防的な素行覚醒というデータですよね。治療的な素行覚醒はどのぐらい含まれてますかね。
We have no therapeutic cases. Unfortunately, therapeutic cases about therapeutic cases we don't know data.
Yeah. I understand.
So,
So basically, what we're saying here, if you look at the data, once surgeons know what they have to do, going into the robotic platform to perform what you know what you have to do would require those 36 cases before you can actually consistently reduce operative time and most significant operative complications. I understand, which is a little different from surgeons who still don't know the anatomical landmarks. That might require even longer a period in terms of cases where they actually need to be proficient in lateral node dissection. Does that make sense to you both?
I agree. Yeah, and also I would point out that actually, interestingly, not only 36 cases, but they show the stabilization of the data around the 20 cases, right? So, of course, 36 cases are ideal to have a better and a more efficient procedure. But the other take-home message from this data is actually at 20 cases with a robot, actually we see more like a stabilized operative time. So in other words, maybe even with a robot, we need like a 20 cases to get more like a stable outcome. So that is something we really need to consider, because in the West, we have less frequent opportunity to do this surgery. And that's a really important data and the drawback from this data set. Yeah.
I'm not sure. Maybe I don't remember exactly. Perhaps he mentioned it. Did the surgeons involved in the study perform bilateral in all patients, or did they have surgeons perform one side and then the others perform the other side? And did it count as one, or did it count as two when they did bilateral?
末田先生、どうでしょう。
この、
両側で1ケースとなっているのか、その両側やると経験数2つになってるんでしょう。この場合、どう数えてますか？
両サイドやって1ケースです。
Okay, so bilateral, one case. So 36 means like a 72 sides, yeah. In this
sides.
That's right, that's right.
So yeah, so it's even more. So it's quite interesting.
Yeah.
Well, thank you. Let's see if the audience have any questions. I think it's an interesting study. Perhaps you, Tsuyoshi, have any questions or any comments that you want to ask?
I think actually we can actually interpret the data in both ways. When we try to translate this data in the Western world, where we do basically only on positive lateral node without the prophylactic setting, and only usually unilateral lateral node dissection. But at the same time, in the West, actually the learning curve is even starting from immature side, right? Because they are already expert. So the start point of this study was actually very high. They are already completely familiar with the anatomy. So just it's a robotic learning curve, but having a better outcome is in a higher hurdle, right? But in the West, we are starting from real more beginner side. So likely the real first learning curve could be even shorter, maybe. So we don't really know whether we need more numbers or even less numbers. That's my kind of impression from the data, because 36 is a big number, but usually we can get earlier learning curve for the real beginners, right? So.
And do you think it would? I mean, how do you feel when surgeons are acquainted with the operation and proficient with the operation on the prophylactic field as opposed to the metastatic field, where is a little bit more challenging in terms of the vessels you have to deal with and so on? How do you feel in terms of when would you feel comfortable in saying that a fellow or a trainee or a junior surgeon has finally completed the learning curve so that he or she can actually tackle the metastatic cases?
Is it a question to Dr. Sueda, right?
Both of you can comment. Both of you, whatever you
First,
think.
I will ask him. So, 添田先生、要はですね、その治療的な速報覚醒の場合っていうのは、もっと、例えばそのラーニングカーブが必要なのか、そのあたりについて先生の印象、データがなくても先生の印象としてはどうですか？そもそもこれはフェローがやってるんですか、それとももっとアテンディング、その慣れた先生がやってるんでしょうか？
まず、先ほど示したような、資格、40例以上の TME、ロボット TME ができる、医師に限られています。で、速報覚醒に関しては、十分経験のある人間がやっています。で、 なぜ今回、速報覚醒を予防的なものに選んだかというと、やはり治療的覚醒というのは予防的覚醒の基礎が成り立った上に、治療覚醒をやるべきだと思っています。特に、血管の合併切除とか、いろんな解剖が理解しにくいケースが多いというのがありますので、ラーニングカーブに関しては予防覚醒よりも定型化ができないという面から、時間がかかるというふうに考えています。
Okay, Dr. Sueda mentioned a very important aspect of this procedure. So when we think of therapeutic lateral node dissection, which often needs a manipulation of the internal iliac vessels, basically the standardization of the procedure is more difficult than prophylactic lateral dissection, where we can completely preserve nerve and vessels, right? That is completely the same procedure for everyone. But whereas the therapeutic lateral node needs more kind of a customization, some partial resection of the nerve or vessel. So he thinks that learning curve for therapeutic lateral node dissection is above this prophylactic lateral node dissection. So that's why he did not include actually the therapeutic lateral node dissection here in this study. Yeah. So may need even more cases in his personal opinion. Yeah.
And can he tell us what in his institution means unsuspected nodes in terms of short axis of the nodes? What does it consider a prophylactic versus a therapeutic in terms of the short axis cutoff he uses?
速報覚醒の陽性に関するその治療的と予防的との分ける基準について教えてくださいということです。もしよければ英語でも日本語でも。
すみません。
例えばサイズとかですね、7ミリとか5ミリとかもし基準があれば。
In our institute, lateral positive lymph node is 7 millimeter.
Okay, so short axis 7 millimeter nodes are the suspected nodes, and unsuspected is anything less than that. I get it. A final question: is he using this learning curve number in any way to consider surgeons that are already, ready to perform lateral node dissection? Is this magic number used in any way to select surgeons who are not able to perform this procedure in his institution or in the country?
質問の内容はこの36例っていうのを今回スタディで出たことで、じゃあ例えばこの数字をこれから例えば先生の施設あるいは日本のJCOL グループでもそうなんですけど、例えばそのサージャンとしてクオリファイ速報覚醒をするのに今後使っていくとかそういった予定はあるんでしょうか。このスタディの次のステップっていうんですかね。これを例えばその指導的な立場にするのに36例っていうこのマジックナンバー36っていうのを実際に使われるんでしょうか。これから臨床でどういうふうに使っていきますか、これを。
これあくまでも、Okay, good question. One major limitation is that this is a single center retrospective study, which may limit the generalizability of our findings. Additionally, all procedures were performed by surgeons who already had experience with robotic TMS, so the learning curve observed here may not directly apply to beginners or different institutional setting. Finally, the study focused only on prophylactic lateral LNNV, so the results may not fully represent outcome in therapeutic or unilateral cases. So further investigate will be needed in the future.
I have one question. There are people texting me from the Western countries saying that because they only perform positive ones, they will never get over the 36 mark. Any suggestions how we could either start doing prophylactic just to improve our learning curve, but that's it's going to be very difficult to support in the clinical setting. Any other ways we could pass this number of cases before we start doing this? Maybe cadaver courses. What do you both think? How do we get to this proficiency state?
Yes. Please go ahead, Dr. Sueda first.
Hi.
Any suggestion to accelerate the learning curve?
Okay. Good question. My main advice would be don't rush the learning process. Take the time to really understand the anatomy, especially the lateral pelvic space. Start with a strong foundation in TME and pelvic dissection, then gradually build up to LND under supervision. Use recorded cases and anatomical diagrams to review nerve and vessel landmark in detail. Also focus on ergonomics and pot placement that makes a big difference in efficiency and safety. And finally, don't hesitate to ask for help or feedback. Mentorship is key to mastering a complex technique like robotic LND.
So adding to his comment, actually, one important, drawback from data is always the anatomy matters. And as Rodrigo mentioned, cadaver training, especially for the Western surgeons, are really important to start with, as well as some didactic course like a video review. So Rodrigo is periodically doing this, lateral node dissection course targeting Latin American surgeons, or actually everyone, sometimes in Europe as well. And it has a very positive feedback from beginners surgeons. They are actually not the beginners. They are already quite established usually in terms of a robotic TME or laparoscopic TME. But when it comes to learning curve for lateral node dissection, always rather than technique, always the anatomy is the key to make it safe and start it with safe in the clinical practice. So I think participating on these cadaver training course and also reviewing the video published already by many authors, including Rodrigo or other, Western surgeons, would help you to learn more quickly. And I'm pretty sure that although 36 sounds like a magic number in this data, but at the initial learning curve to make it safe is much shorter. As shown in his data, like a 20 case or even shorter, like even 10 cases with enough video reviewing would be quite feasible to make it feasible. Yeah, in my opinion. Yeah. Rodrigo, you are muted.
I see some people in the audience with a raised hand. I would ask you to send the questions through the chat. We are unable to open mics from our side, so if you could send us the questions through the chat, I would appreciate. Before we get any further question, I would ask you a final question. So what's next, Dr. Sueda? What is your idea to study next in terms of robotic lateral node dissection once it looks like you've determined a very consistent learning curve cutoff? What are you going to study next in this area?
さらなる研究ということですよね。
そうですね。次のこのデータの後、じゃあ次先生の研究トピックとしては何を考えてますか？
一応今これリミテーションで説明したように、シングルセンターですので、やはり大規模なセンター、いろんなセンターを含めた、さらに多くのサージャンを含めた、ラーニングアームの検討が必要ということと、今回議論になったような治療的覚醒に関して、あるいは、腹腔手術との比較ですね。それが、次へのステップとして考えています。
Okay, he's thinking the next research topic will be, for number one, making this single center study to multi-center study to validate the data. And number two, he is thinking of, investigating the learning curve for the therapeutic lateral node dissection, not the prophylactic setting. And that is his main consideration right now. Yeah.
Yeah. Dr. Malik is making a comment that there are ways to work around the learning curve by looking at YouTube videos, choosing your trainees appropriately. I think you have addressed the issue of having trainees who have already surpassed the anatomical landmark issue in lateral node dissection, which is quite significant. But I strongly feel that there should be some kind of structural training, and I like the idea of looking at learning curves to specific parameters. That's why I think this is a very interesting study. I don't know if
And
you have
also
any
he,
further
sorry,
questions. Yeah, go
only
ahead.
one comment. Yeah. Also, he mentioned on the comparison of the learning curve between the robotic procedure and the laparoscopic procedure. That is also very interesting because I believe also laparoscopic lateral node dissection is also performed in everywhere, including Latin America and also Europe. And actually, they also show quite a good learning curve. So I think that's a very interesting topic as well. Yeah.
Yeah. I think this is interesting to see in the future whether there are any differences in terms of laparoscopic and robotic learning curves. And I honestly think from my side, having somebody who's also proficient in terms of looking at the anatomical landmark actually helps you during the procedure itself. And I think when you transition to the robot, you need to be at a different level because you're often on your own and you have to understand exactly what you're doing. And sometimes having somebody who's also proficient with you helping the procedure actually helps. And I'm not sure if Dr. Sueda wants to make any final comments, and Tsuyoshi, if you have any interesting comments to close this discussion.
Yes. So I really want to congratulate Dr. Sueda for performing, this unique data, which is likely available only from Japan. But I would, really highly encourage to further explore multi-center data, especially in some of the institutions in Japan. They do chemoradiotherapy, neoadjuvant therapy, likewise in other, countries, and they usually selectively do lateral node dissection, likewise in the Western world, only for therapeutic patients. So these data would be also something very interesting for the Western surgeons as well. And also, I would really, encourage everyone to look at the, data not only from Japan but the Western world. Some data are available from Korea and also from US as well. We recently worked on our own data from MD Anderson, and so there should be more data coming. And this is a quite interesting research field. Yeah, thank you for showing your data, Dr. Sueda.
Okay, thank you. Thank you, Professor Perez and Dr. Konishi. I want to conduct about future study.
Okay, excellent. So thank you, both of you. Thank you for everyone who was connected. This discussion will be available in our YouTube channel shortly, and we will get in touch through social media for the next virtual session for techniques in coloproctology. So thank you very much. You have a good day, Dr. Sueda. I know you are ahead of time. You are already starting your day, and we are all of us in the Western world finishing our day. So good night to everyone who's connected. Good morning to everyone who's in Japan and the other side of the world, and we'll see you next time. Thank you.
Thank
Thank
you.
you.
Thank you for watching. The published article discussed today can be found at the link below. For more TCOL content, go to springer.com and be sure to subscribe for notifications about future virtual sessions. Follow us on X and LinkedIn. See you next time.